Welcome, everyone, to the May 4th COVID-19 clinical care rounds focused on emergency medical services, patient care, and operations. I'm John Kramer. I'm an emergency and EMS physician who serves as the team lead for the FEMA Healthcare Resiliency Task Force, EMS pre-hospital team. I'm also the director of the NHTSA Office of Emergency Medical Services at the U.S. Department of Transportation. The purpose of these sessions is peer-to-peer, real-time sharing of COVID-19 EMS challenges and successes in patient care and operations. This is a voluntary public-private collaboration, and we express great thanks to the multiple professional organizations who have collaborated in this series. It's not intended to be redundant or replace other organizations' initiatives. Although this particular session will be a little bit different in specific focus, the series is intended to be a sharing of clinical experience and not recommendations or guidance. The ECHO clinical rounds that you're now participating in are focused on clinicians sharing their successes and challenges in patient care and operations with other clinicians. A special thank you to Project ECHO, Dr. Bruce Struminger and his team for the peer-to-peer learning platform that we're using for these rounds. At this time, I'd now like to ask Dr. Struminger to cover a few logistics issues. Bruce?
Great, thank you, John. And I want to thank all our participants. There are over 600 participants joining us today, and our panelists and subject matter experts who have joined us. So a few housekeeping items. First, we want to reserve, there's a Q&A function in the Zoom toolbar at the bottom of the Zoom screen. Please put your questions and comments regarding the presentations and today's topic in the Q&A. Also, please use the chat function for questions about technical and logistic issues. And we will be actually asking you a crowdsourcing question, and it'll be more open-ended, and we'd love to get your feedback to that question in the chat. These sessions are being recorded. Your attendance is consent to be recorded, and we thank you for that. The slides and a link to the video recording will be shared after the session via an email announcement to everyone that registered. They will also be on a website that Project ECHO supports, and we'll give a link to that. And in reminders that follow this, there'll be links to past recordings accessible there. There will be CME and other continuing professional development credits available through the University of New Mexico. We'll be putting a link in the chat at the end of the session, about 15 minutes before the end. There's also a link in the most recent announcement that went out about an hour ago. So if you go to that announcement you received, you can find the CME link there. We love giving you the continuing professional development credits. We also love getting your feedback when you fill out the survey to get that instant CME. So we really encourage you to take advantage of that. It helps us improve these programs. With this, I want to hand the microphone over to Sharon to give us a little overview of the NETech webinar series focused on COVID-19. Sharon?
Thank you, Bruce. Hello, everybody. My name is Sharon Van Aersdale. I'm the Program Director for Emory Sears Communicable Diseases Unit and the Director of Education for the National Emerging Special Pathogen Training and Education Center. And it's been really great to be able to partner with ECHO and continue these webinars into like a deeper dive. So the upcoming webinars that we actually have from NETech is the long-term care, so strategies to care for vulnerable populations. So you might have been part of the ECHO webinar on Friday, and this is a deeper dive into that using some case studies to talk through a little bit more. And then we're also doing kind of a different forum. It's called PPE, You've got questions, we've got answers, and this allows you to submit your questions in advance so that we can really focus on what topics you'd like to discuss when it comes to personal protective equipment. So please check out NETEC.org with our training and education site, and you'll be able to hear, you'll be able to see more information there.
Great. Thank you, Sharon. I just want to highlight that the American Association of American Medical Colleges has developed a wonderful clinical guidance repository. It's found at www.aamc.org, COVID-19 guidance, and encourage you to check out that clinical guidance repository. It's got a lot of wonderful resources. Next, I'm going to hand the microphone back to John.
Thank you, Bruce. Just a couple of quick references to some upcoming ECHO COVID-19 clinical round series. Typically, the series generally occur at noon Eastern Time. Tomorrow, May 5th, there will be a clinical rounds on critical care life-saving treatment and operations. That'll include some updates on the management of ventilated patients, issues addressing the care of renal failure patients, and some other critical care operational issues. On Thursday, May 7th at noon Eastern Time will be the COVID-19 clinical rounds in emergency department patient care and clinical operations. So typically the weekly schedule is Monday, EMS issues, Tuesday, critical care, Thursday, emergency department. All of the sessions are archived and, as Bruce mentioned, available for review. We've been very fortunate on these ECHO clinical rounds. We've had participants from all states and multiple countries, predominantly physicians, nurses, and EMS clinicians. As Bruce mentioned, we have the opportunity of doing some crowdsourcing. So our crowdsourcing question for this week: in the last 7 days, what is the best operational change your EMS system has made in response to COVID-19? And when you indicate your response, please indicate the state and country in which you live. The polling questions that we have available will be: in the last 7 days, are patients being seen by your EMS system sicker because they've delayed seeking care? Either yes or no. And over the last 7 days, is your access to PPE while caring for patients better, worse, or the same?
John?
Please, go ahead.
This is Bruce. I think we're going to come back to those polling questions, and we'll actually put them up on the screen so that people can select them. But I think we may do that maybe after the first presentation or so.
Perfect.
Okay.
Thank you.
We gave people a preview. Great.
Our speakers today: David Gerstner, EMT paramedic, has been with the Dayton, Ohio Fire Department for 40 years. He currently serves as the Regional Metropolitan Medical Response System Program Manager. Among other activities, he coordinates the Regional MMRS Rescue Task Force for EMS response to active shooter and terrorist events. Mr. Gerstner is a clinical faculty member with the Wright State University Boonshoff School of Medicine and an EMS instructor. He is president of both the West Central Ohio Regional EMS Council and the Greater Montgomery County Fire Chiefs Association. Dr. Carol Cunningham is the state medical director for the Ohio Department of Public Safety Division of EMS and is an associate professor of emergency medicine at the Northeast Ohio Medical University. In addition to her accomplished emergency medicine and EMS career, she is an avid musician and is on the board of trustees of the Rock and Roll Hall of Fame and Museum. As I mentioned earlier, our presentation today is going to have a little bit different focus. Carol's presentation will include issues of helping to coordinate the state of Ohio's EMS response related to COVID activities. But she was doing that from a locked down rehabilitation center, having just had a significant orthopedic procedure. We have consequently asked her to talk about her experience as a healthcare provider while being housed in that long-term facility and helping to support Ohio's activities during the COVID response. With that, I'll turn first to Dave Gersman. Dave.
Hi, John. Give me just a moment here to get the slides going. All right. So first, I'd like to say thank you to Dr. Kramer and Dr. Hunt, both of whom graduated from Wright State's emergency medicine residency program a few years ago. I'll be kinder than Dr. Kramer, but thank you for asking me to join today. Dayton is one of 124 cities around the country that's been an MMRS city and received funding for preparedness. We have continued our MMRS program, as have a number of other cities, after the automatic federal funding stopped, and we continue to get funding from our regional hospital coalition, from public health, and sometimes from the Homeland Security Grant Program. We also work with the MMRS National Leadership Group and are always looking for opportunities to get additional funding for MMRS cities all across the country. We serve the West Central Ohio area, a region of 8 to 10 counties in West Central Ohio. And MMRS has long been known as the Bring It All Together group. So we started collaborative planning well over 20 years ago. And everything we do is based on collaborative efforts. So we work closely with the Greater Dayton Area Hospital Association and all of the hospitals in the West Central Ohio area, as well as with EMS, law enforcement, federal agencies, emergency management agencies, public health, and many, many others. We actually started pandemic planning in 2002 and started doing crisis standards of care, which at the time we called altered standards of care planning, in 2006. We do lots of exercises, and the exercises range from terrorism and chemical weapons to active shooter incidents, but we have done multiple pandemic influenza exercises, and in fact did an exercise titled Pandemics Are for the Birds on February 11th of this year, as we were dealing with a real world pandemic that was developing at the time. We've also done a lot of work around Ebola. We have a West Central Ohio biological response plan that deals with a number of special pathogens. And we have a regional collaborative plan for transport of Ebola and other special pathogens patients that includes use of specially prepared medic units, such as the one that's depicted here. We quickly decided that these units were not appropriate for the COVID pandemic for a number of reasons. However, we do feel there may be some use for this, particularly for certain patients, such as patients who are in facilities and are on ventilators long-term, and when those patients have to be moved to a different facility. And again, in the midst of the pandemic, we did still another exercise. We had a statewide Ohio exercise called OHI Know It's Ebola, where we transported simulated Ebola patients across multiple regions of the state of Ohio. We were very involved with the last pandemic, the H1N1 pandemic in 2009, 2010. And as Dr. Cunningham well knows, EMS was very involved in the vaccination response to H1N1, and that was certainly true in my region of Ohio. We were also involved in terms of respiratory PPE at that time, and we purchased a number of PPE items, and we had specifically purchased N95 masks at the time that did not have an expiration date. And that was fortunate because we did not use all of those masks for H1N1, and now are using them for COVID. One of the things that we've done with all of our purchases, including for PAPRs as well as N95s and surgical masks, is that when we bought large quantities of masks and were able to get a significant discount in the price, part of the bid ask was that the company who was awarded the bid would be able to provide that same pricing for any of our partner agencies. And so we were able to leverage that money. MMRS bought 250,000 N95 masks, but there were thousands more masks that were purchased by specific agencies around the region at that special pricing. One of the things that we do is work with our regional EMS council, what's called the Greater Miami Valley EMS Council, public health, law enforcement, and others, and put together guidance documents and informational bulletins for public safety during response to incidents such as COVID. We've done this during H1N1. We've done it during the various Ebola outbreaks and other situations. And in fact, we put out our first coronavirus bulletin on January 22nd of this year. We started watching it, what was going on in Wuhan early in January, and then put out our first bulletin mid to late January to let others in the region know about this. But we quickly determined that there was going to be a lot of information that would be needed by public safety in this region. And so we put together a web page specifically for public safety in our region. Dayton MMRS has a website, but it is a vetted website and it requires that people be approved to get entry, and we didn't want that. We wanted to make sure that this would be widely available. So we used Greater Miami Valley EMS Council's public-facing website to put together our COVID for public safety webpage. And the URL for that is at the top of this slide. It's just gmvemsc.org/COVID-19. And as you can see, we have sections for EMS, for law enforcement, for dispatch, some training information, and a multitude of situation reports that we post daily. We've dealt with some of the same challenges that everybody else has when dealing with COVID. Certainly, we've had problems with the changing recommendations for PPE over time, and we've seen that in other situations. We saw the same thing with SARS. We saw the same thing with H1N1. And we've had a lot of shortages, but we've worked together, again, collaborating. So we use the MMRS cache of PPE materials and then work with our public health agencies and our emergency management agencies, and for the most part, have been able to get adequate, not certainly everything that we would like, but adequate supplies of PPE for our region. We've worked with EMS, particularly on hospital notifications and protection. We not only notify the hospitals when we're coming in with a suspected COVID patient, but we do things like stop aerosol generating procedures as we move through public areas of the hospital. We've spent a lot of time talking about alternate transport or no transport policies, and that's been very challenging, partly because of the wide array of illness that's been seen with this disease and the wide array of symptoms and the challenges with recognizing a patient who's likely to deteriorate. And so we have not implemented any of those policies, but in fact, we have found that we didn't need to. EMS run volume in our region is significantly below. And so the bottom graph is a day-to-day graphing of what Dayton Fire Department is seeing. And this is pretty much true of EMS agencies around our region. The top of this is what we would normally expect to see this time of the year. So to make it a little bit easier, 2020, our run volume is down 17% in terms of EMS runs over what it was this same time period. So this is for April of 2020 and April of 2019. We're down 17% from what we saw in April of last year. We have put together a guidance document on cardiac arrest and termination of resuscitation. The American Heart Association put out interim guidelines on this that we found very helpful and made use of a lot of that. And as they recommend, we tailored it to be specific to our area. We've done a lot of work reminding EMS to make sure that they check for and honor DNR status, to use field termination procedures whenever appropriate. One of the things that we found that's been controversial is CPAP versus endotracheal tube, and we have recommended that in respiratory failure that CPAP be tried first to try to preclude the need for doing intubation. And I recognize that there are arguments to be made on both sides of that case. But we've also talked about appropriate protective procedures for intubation and for other aerosol generating procedures. Finally, our cardiac arrest guidelines that are on the website include additional levels based on when call volumes are dramatically up. Since we haven't had that, we have not implemented any of those additional levels. We put out information for our dispatch centers, and one of the things that we have throughout Ohio is that the local health department notifies each dispatch center of positive COVID test results. And theoretically, this is to warn EMS and law enforcement when they're responding to such a location. I think that has kind of, I'm not sure of the value for that. We are largely using universal precautions, but retrospectively, it's been useful. We've found several cases where law enforcement had contact with someone who tested positive just a few days later. And law enforcement was not aware that it was a concern at the time. So that's been helpful. We've dealt with some lifestyle issues. We've recommended that EMS and law enforcement use surgical masks when out in the public and on duty. And of course, using N95s or PAPRs for aerosol generating procedures. But we've also recommended use of cloth masks in the station. We have some locations in our region that have bunk rooms that don't have dividers or adequate separation. And so at least one of our agencies has done things like flip-flop bunks so that the head is at one end and the next person's bunk, their feet are at the same end. We recommended, again, surgical masks for law enforcement and provided cloth masks for law enforcement to provide for anyone who is in a public safety vehicle. One of the things we've had a challenge with is social distancing in the EMS rooms at hospitals, and everybody tends to congregate there. So we've had to remind people of that a lot of times. And finally, we've dealt with rumors, and that's always a challenge, and we've tried to discourage rumor mongering. Hopefully, we are now entering a bit of a breather, and so my kind of message that I'd like to convey is use the time if we are in fact entering a breather. The director of the CDC has said that a second wave is inevitable. So start preparing now. Do everything that you can, think about every possibility and start preparing. Things like, how are you going to document if your run volume increases dramatically? How are you going to deal with personnel rest and certainly personnel mental health? As testing materials become more available, should EMS become involved in the testing processes? And certainly I would encourage EMS around the country to get involved in vaccinations when we hopefully soon have a vaccine. So some of the people on this call will not remember Y2K, but at the time we thought this was going to be a huge problem when computers didn't know how to change from 1999 to the year 2000. And so there were all kinds of predictions that Y2K would be this horrible thing and that everything bad that you can imagine would happen as a result of Y2K. And of course, nothing happened. It was a non-event. But the reason I bring this up is that the work we did preparing for Y2K, oddly enough, helped us respond more effectively to a tornado in our region just months later. And so anything that you do to prepare helps you be better ready for the next problem. Preparedness always pays off. And I hope everyone on this call will use this opportunity to be better prepared. John, let me stop sharing and I'll give this back to you.
John, you're still on mute.
Shame on me. Thank you, Dave. Really appreciate those comments. And Bruce, thank you for noticing that. And thank you for all of the participants who have been sending in a lot of comments and a number of questions. We will circle back to those in just a minute. Bruce, if you can pick up the screen and post the polling questions, we'll go through a couple of questions here and then turn it over to Carol and then come back to a number of the discussions. So folks who are participating, in the last 7 days, are patients being seen by your EMS system sicker because they've been delaying seeking care? Answer yes or no. We'll go for about 20 seconds here to give you an opportunity to answer. And just for Carol and Dave's perspective, unfortunately, you can't vote. Sorry about that. All right, let's go on to the second question, please. Over the past several days, is your access to PPE while caring for patients better, worse, or the same? Uh, 5 seconds left. All right. Thank you, folks. And thank you, Bruce, for sharing that. I'd now like to turn it over to Dr. Carol Cunningham, who will talk a little bit about Ohio responses, but talk about the perspective of being locked down in a long-term care facility. Carol.
All right, thanks, John. This is a different topic than I'm used to discussing. It was actually a very educational experience. I'm gonna open up the screen here and to this PowerPoint. There we go. Okay. A lot of what I've experienced was actually posted in an article that was posted on GEMS. I have that link there if you care to look at it. It's called The Human Side of Us, that I wrote on Palm Sunday while I was in the facility, as well as a link to Ohio EMS. So you can take a look at some of the guidances that we wrote, and some of those, many of those I wrote while I was in the facility. Just to kind of give you an overview, this was not planned. I was scheduled for an elective surgery that was going to require about 7 to 10 days of inpatient rehab, followed by outpatient physical therapy, primarily because I'm single, I live at home, and there's 17 steps for me to get up to anything in my house. Once I arrived there, and I selected the facility because it was approximately a 5-minute drive away from my aunt, who's my last remaining relative here in Cleveland. Little did we know how things would escalate. This is at the beginning of March. I was there less than 48 hours when, due to COVID, the facility went on lockdown with no visitation permitted whatsoever. Following that, there was a stay-at-home order that was initiated by the governor's office. And as a result of that, that temporarily closed home health agencies. So I did not have, my only avenue to get physical therapy was actually to stay at the facility, as it was for many other patients there. Our initial stay-at-home order was extended to May 1st. However, there was some latitude in the interim for that to allow essential businesses to maintain their functioning, and eventually they got some outpatient facilities. Shortly after I was there was a COVID outbreak in the nursing home that was literally blocks away. And that really changed the script. I think that's when we started realizing that when people were in communal living situations, that it was more at risk. Following that, there was a mandatory 14-day quarantine for any new admissions. Fortunately, I got there before then, so I didn't have to stay in my room. I had actually, I could actually go out to physical therapy. But for those folks who were just admitted, they literally could not leave their room for 14 days. And if they needed things like physical therapy, it was done actually in their room. And then following that, there was a mandatory use of face masks for anybody. If you left your room, they of course did temperature checks. And then eventually they moved anybody who was in a 14-day quarantine into a separate hallway, which caused me to have to move into a different area, which was fine. And actually that was easier on the staff because they could have the PPE on the doors in one hallway and and not have to remember so much if they were scattered about the facility. But long story short, my initial 7-day stay turned into 41 days. So 6 weeks literally in lockdown with no direct contact with friends or family. It actually gave me a great view of the human side of this. And I think as we're writing our protocols, we're thinking about the administrative and the operational scenarios. But we also have to remember that we're in the people business. And excuse me a second. Excuse me, I had a dry throat there. That all of us, including myself, we're human beings. It gave me an opportunity to actually discuss how the staff was handling this. And in that, everybody had fear back then, and just as there's fear now, we're dealing with a virus that doesn't have a known effective treatment. There's no vaccine. And even as a care provider, you don't know which patient is going to require a ventilator and which one is just going to have mild cold symptoms. The facility that I was at, I really feel very fortunate. Despite that, they were very nimble in changing their procedures as necessary. But again, talking to the staff, they were very fearful about going home. How would they manage going home to their children? Many of them were taking care of elderly relatives. I was on a conference call with my physician group, and like many of those people who were working there, I had, there were many physicians in our group who were coming off of maternity and paternity leaves right in the middle of this crisis. And how do you, as a parent, go home to a newborn knowing that you've potentially been working around this virus? They were looking at what happened down the street. There were staffing shortages. The facility that had the outbreak not only had patients that were infected, they had one death as well as several staff members. And there were staff that all of a sudden weren't showing up from work. And they were offering huge bonuses to get people to go there, but I'm not even sure if they were able to do that. And then I think we forget too about some of the intangible losses that the employees would have. As an example, the staff among themselves actually had like a plan. Some folks didn't feel comfortable going home with their families, so they had their families stay at relatives' homes. And I remember one of my physical therapists, his son had his fourth birthday party, and he's very close to his sons. And I give this guy credit because he's a hands-on dad, but he couldn't even bear the thought of connecting by FaceTime because it's not the same. It's not the same of actually being there and being able to be part of the party and hold your kid. And then from the patient side, those people who were transferred in, who had mandatory 14-day quarantines, many of those did not realize this procedure was in place. I think, I doubt that the hospital told them that when they came there. And as you can imagine, here you are just recovering from something significant, and you're in a room by yourself literally all day long. The prolonged isolation, I think, would affect patients differently. There were some long-term patients and some demented patients who really didn't understand why they couldn't see their family. And certainly for someone who's elderly, regardless of all the medications that they're on, sometimes holding their hand or waiting for their grandchild to come up is the best medicine ever. And all of a sudden it's gone and they don't understand why. As a result, you could see some of them just becoming more depressed, not eating, to the point where they would have to be transferred to the hospital because of dehydration. You know, you can't force somebody to eat. And then some of the behavioral outbursts, you know, people just getting angry and yelling and things like that. From my own personal experience as a patient, you know, when you go to the hospital, you take very minimal equipment with you. You don't have checkbooks, you don't have your cash, you literally don't take anything because they don't want you to lose anything. The facility where I was located was out in the middle of the woods, and my cell phone wouldn't even work properly because there wasn't a cell tower that was adequate enough for me to be able to communicate. The telephone system, it was an older building, was a simple phone with no voicemail and connected to a centralized computer that would frequently go down. If this had to happen to anybody, I think I'm glad it happened to me. I'm single, I live by myself. I don't have kids. I've got 8 godchildren that all live out of town. So my house is full of teddy bears so that when the kids come over, they have a great place to stay. But this really, there were times it really tested me from a personal standpoint. For communication, I gotta really thank, I have a fantastic office staff at the state. We made it work in partnership with a guy by the name of Cy Brennan, who was the IT guy at this facility. If the computers or the phones went down, he would even come in on the weekend to get me connected to my state office. And quite frankly, if you look at the guidances that are on the website, a lot of people didn't even know I was in a facility until I was on a Center for Homeland Defense and Security webinar, and I thought it was just going to be audio. And 2 minutes into it, Chris Bellavita asked me to turn on the video, and of course there I am in a hospital bed, curled up next to a stuffed dog, Patrick, that a friend of mine gave to me. And I think people were kind of surprised, but then Patrick now has become known as Pandemic Patrick. I was in for 41 days because when this happened, my aunt was already at home and had my clothes. I was in a hospital gown and anti-slip socks for 41 days. I had my computer, and that was about it between Patrick and my iPod. So I think I can manage anything. You know, Dave mentioned Y2K. I was in a hot tub in Aspen, Colorado, toasting the Rockies. For Hurricane Katrina, I was in room 170 at the Grand Hotel. But you still, manage these kind of things. But from a human standpoint, I'm always want to be there for when my friends and my family have troubles. And probably the times where I was at my breaking point was a day when I found out that the first death in my county was from COVID was actually one of my EMS providers. At the same time as my dear friend who gave me Patrick, he lives in New York City, and he was fighting for his life against COVID. And to listen to him gasp for breath over the phone and not being able to help him and his family was awful. Then there was the hospice situation. How do you go into a nursing home when hospice is, you have hospice there, you want the family to come in, but they're on lockdown. My best friend's mother had a stroke and was enrolled in hospice in a nursing home, and to try and negotiate with them to have some flexibility to let him come up, drive up 4 hours and say goodbye to his mother and not be kicked out in 10 or 12 minutes, whatever the rule was a challenge. And I think we have to remember that human aspect of it. I learned a lot about the disconnect that still remains between many of our agencies that are partners in running the response and EMS. There were some policies put out by our state without my knowledge that I never would have known that they were there until I heard about it kind of through the grapevine or through an EMS complaint. And then I'm like, wow, nobody asked us about this. If we had seen it, we would have fixed the gap. But moving forward, you take those as opportunities and try and make sure that EMS is at the table, at least put out the welcome mat. We're all in this together, and I think that there's probably never been a more time I've been proud to be from Ohio. I think Ohio's doing a great job. Nothing's perfect, but we're certainly moving ahead. At my lowest moments, I really felt like Tom Hanks needed to get better. I felt like I was filming the sequel to Castaway. If you've ever been in a room just really in solitary confinement for 6 weeks, people would be like, gosh, why is she hanging on to this stuffed dog? Well, Patrick was my Wilson, and when you're in a room and you haven't talked to any human being directly other than the staff coming in periodically, it's those kind of things that will get you through and certainly make you stronger. The other things that I would mention, just moving ahead, I know Dave talked about preparing for the future. Protected healthcare workforce means all of us. EMS is a practice of medicine, and we need to be valued equally as those on the front lines or anywhere else, but also, you know, the staff at these facilities are part of our workforce. I don't care if you're the janitor. You can't run an operating room unless it's clean. You can't run a room if it's clean. So I would ask ourselves, you know, when's the last time you actually sat down with some of your housekeeping help and taught them how to put on PPE? Because without them, we still can't keep our facilities clean. So make sure you include everyone. You know, there's a lot of challenges for the future. Everybody is looking at, you know, when's the vaccine going to be there, et cetera. I'm thinking more long term. We are taking an economic hit on this, and how are we going to manage the surge as well as future pandemics as this goes on, you know, potentially for another year or 18 months at least, knowing that there's less resources financially out there to support us? And how are we going to support our workforce to prevent mental health breakdowns and suicides, which I mentioned in my article, which is now unfortunately become a reality for some of our providers. And then we need to look at innovation, you know, telehealth. Is there any way we could use telemedicine even at the door of the emergency department to comply with EMTALA regulations, again, for protection of the workforce? But anyway, thank you for the opportunity here. I'm off the island now and I'm back at home, and Tom Hanks can go back and get casted for the sequel to Castaway. Thank you.
Carol, thank you so much for the perspective of a healthcare provider and as a patient, and not only as a patient, but a patient in a lockdown facility. Quick question for you. Did folks in the facility know that not only were you a physician, but you were the state EMS medical director?
They didn't when I arrived. I try and maintain the anonymity. You know, I'm just Carol. But when I thought I'd be able to work on my own, but I eventually I did have to tell them, especially when I realized that I didn't have cell phone connection, and I needed to schedule my PT around some of our state briefings, et cetera. So yeah, after that, but I told her, I said, that's my job. Here, I'm Carol, I'm a patient. I'm here for physical therapy.
Thank you.
And they appreciated that. And I made sure they knew who Patrick was, so.
I'm going to go around to the discussants in just a second, and I'll ask you to introduce yourself. Dave, a quick question from some of the folks in the audience. Has your area peaked yet? Do you think your volume decrease was due to folks social distancing and sheltering in place, fear of going to the hospital and potentially being exposed?
John, I think it's all of the above. Obviously, we can't really know why people are not calling, but we've seen a decrease in calls across the board. We're seeing less shootings. We're seeing less auto accidents. We're seeing just lower EMS volume. We're seeing lower volume in the emergency departments in most of our region. The governor of the state of Ohio, Mike DeWine, and the director of the Ohio Department of Health, Dr. Amy Acton, have been very, very much in front of this from the start and have pushed social distancing, and I think clearly that's had an impact. There have been some people who've done some attempts at questioning individuals and asking, is there a fear of going to the hospitals? And yeah, I think there is some of that. But it's a little bit of everything. But overall, we know we have not peaked. We've had the opposite of a peak. We are in the valley. So less EMS volume, less ED volume, both of which seem to be starting to come back, but neither of which are up to where we would expect them to be normally, let alone having a peak from the pandemic. And certainly that's not been true across the country. And there are places that have had to deal with some horrendous volume. But so far we have not.
Thank you. I'd now like to turn to the discussants on the panel, and we'll very quickly just go around and have you introduce yourself and then come back and comment on some of the information that's either been presented or that have come up in questions. Sharon, any additional introductory comments that you want to make?
I think I got a good opportunity to introduce myself, so thank you. Appreciate it, John.
Great, thank you. Dave Tan.
Hi, I'm Dr. David Tan on Emergency Physician University in St. Louis, president of the National Association of EMS Physicians.
Okay, at least in mine, Dave, you were filtering in and out a little bit, so we'll come back and check on that. Robert.
Yes, I'm Robert McClintock. I'm the Deputy Director of Fire and EMS Operations with the International Association of Firefighters.
Thank you, loud and clear. Doug.
Yeah, hi, Doug Kupas. I am on as an NAMSP board member, but also serve as an emergency physician and EMS physician with Geisinger Health System in Central Pennsylvania, and as the Commonwealth EMS Medical Director for the Bureau of EMS in the state.
Great, thank you. Paul?
Paul Bittinger, Emergency Physician, Director of the Center for Disaster Medicine at Mass General Hospital in Boston.
Thank you. And Alex?
Hi, John. Hi, all. Alex Isakov. I'm Emergency Medicine and EMS Physician at Emory University and the EMS lead for NETEC.
And not to be forgotten, Dr. Hunt. Please introduce yourself.
Rick Hunt, Senior Medical Advisor for the Healthcare Preparedness Program at HHS ASPR. Thanks.
Thank you all. Before we go into some of the other questions that have been submitted, for the discussants, any comments on any of the information that Carol or Dave shared with us?
John, this is Dave Tan. I think what Dave Gerstner said as far as preparedness really rings true. Preparedness in any form has a downstream effect and can be very beneficial, regardless if you're preparing for tornadoes, Ebola, what have you. So that's really important. And to Dr. Cunningham's point, I really think her perspective as a physician and as a patient really highlights something that we have to consider for future pandemics and maybe even a second wave of COVID, is if there is one, and that is what are we trying to do? Are we trying to eliminate risk, or are we trying to reduce or mitigate risk? Because if you try to just eliminate all risk, that has tremendous economic impacts, human toll, mental health consequences that I think we'll be seeing for months, if not years to come after this initial COVID crisis is over. And so I really appreciate what Dr. Cunningham highlighted and how important it is for us to consider that in the future, because there has to be a way to balance risk without causing such an emotional toll on people. And that's something that we really need to consider.
Thank you. Yeah, I agree with that completely. There have been a lot of comments that have been made on previous sessions here, and certainly with other engagements with the community, about the behavioral health and mental health issues, not only for the community that we serve, but for the clinicians that are involved in taking care of them. Focusing here, obviously, on the field clinicians, but other healthcare disciplines and folks in the emergency department throughout the hospital. Dave, you mentioned a comment about addressing rumors. What kind of rumors?
Well, we've had inappropriate postings on Facebook by some EMS providers. We've had some of the usual conspiracy theories, the stuff that has gone around about was COVID actually a bioweapon as opposed to simply a zoonotic disease. We had an unfortunate case that wasn't actually a HIPAA violation, but an EMS provider shared that someone had been taken out of a school with possible COVID, which was actually not true, but it certainly started the rumor mill flying. So we've tried to encourage people to be cautious both in what they say and especially in what they post.
Any comments from any of the discussants? Oh, come on, guys.
John, I noticed a couple of comments in chats. Some people remarked, I said calls were down across the board, and some people pointed out some things that we are also seeing in our region. It's not really true that calls are down across the board. We're seeing an increase in overdoses, both in terms of meth and opiate. And we're also seeing a significant amount of domestic violence. Probably, and I don't have hard numbers on this, but probably higher than what we would have seen normally in this time of year. Certainly, Ohio has been very hard hit by the opioid crisis, and that's ongoing in my region. And we watched those numbers very, very carefully, and we did start seeing late March and throughout April increases in overdoses.
Well, Dave, I think, you know, at least in where I live, we've actually seen an increase in suicides. As we look ahead of this, when we look at decreased run volume, some people are afraid of getting COVID at the hospital, but also you hear these stories about once that loved one goes in the hospital, they disappear. You can't go see them, you can't visit them. So why would you want to go to the hospital? You know, you don't want to be separated from your family because of the hospital rules. And if they end up getting into the ICU, that may be the last time you see them. As we address the mental health issues, I think we need to not only look at things to mitigate, but look at rates of, as you mentioned, is there going to be an increase in substance abuse in our EMS communities, suicides in our EMS communities? Look at divorce rates. I think that, you know, we saw this happen after 9/11, and it happened for months afterwards, but that was a one-time event. You know, when we look at the Crisis of Standards toolkit, and I was on the committee that wrote the EMS section of the toolkit, one of the first things I did when I came home, I was like, oh my gosh, I hope we address the mental aspect of it, you know, that you need to have that on the plan. I was glad, you know, that was written 10 years ago, but it's there. This is an ongoing event. So I think the backlash and the dings in the armor in our providers are going to be greater, just because this is gonna last for months, and will probably make some of the after effects of 9/11 in terms of that mental health and resiliency be pale compared to what we're going to see, you know, 2 years, 5 years from now.
Thank you. Folks, we are approaching the top of the hour, but I'm going to suggest if the panelists and discussants have a couple of minutes, we'll continue just for a few minutes past that. Doug, you had a comment you wanted to make?
I was going to make a comment. I think, you know, not everywhere, but many places do see this lower volume of trauma, maybe higher with assaults, but certainly motor vehicle crashes and other traumas are way down, you know, across our state. that as I see places, both hospitals and EMS systems, starting to change some of their plans, sort of feeling like, well, the big wave we were expecting didn't really hit, so now we have to sort of go a little bit back to normal operations. I think that I would just caution folks to do that in a way that allows you to immediately return to the plans that have been made for a surge, because we certainly don't know where things are going to surge in either pockets or across wider areas as things go forward. But the other thing that is of interest to me is I think that the public is going to be, and this is my personal opinion, is going to be so concerned about this that we might see an extended period of time, maybe a year, of decreased EMS volumes, people actually changing their culture and not calling EMS for everything. And I think this could be very disruptive. It's a direction that some have felt that we need to go to sort of decrease the EMS volume of calls that are not as high acuity. But I think EMS has to be ready to use this disruption to change our future operations. And, whether that is more MIH type things, telemedicine things, et cetera, this disruption may dramatically change where we go for the next decades.
And Doug, when you mentioned that, I always have to say this because I lived in a semi-rural area. My greatest concern is with our rural and volunteer EMS agencies. When you're making those plans, make sure you include them. With this economic downfall, we're seeing closure of critical care access hospitals at rates we've never seen before. And now you've got patients who may have, 15-minute drive now going an hour, 2 hours away. The rural and volunteer EMS are important links in our chain. And if we leave those links weak, our whole system is going to be weak. Thank you.
Thank you. We've had several questions come up, and I'm going to loop them all into one question, maybe for Paul, Robert, and Sharon. And Bruce, while we're doing that, do you have the ability to at least show the results of our polling question, just to put them up in the background so folks can see that? But for Sharon, Paul, and Robert, we've had several questions about PPE issues. There's been a lot of controversy. Gowns versus coveralls in the EMS environment. Do they have to be disposable? Can they be reusable? And if so, how do we decontaminate them? Any perspective on sort of that three-part question? PPE, disposable versus reusable, and how can they be decon?
Yeah, this is Sharon. I'll start, and then I'll see if my other colleagues here would like to say something. So PPE is always a hot topic. It was a hot topic back with Ebola. It's something that has been persistently talked about. I think that it really does depend on your situation. We are finding new innovative ways to reuse personal protective equipment if it can be done safely. I think the key principles are, making sure that you know how to put it on and take it off. Coveralls and gowns provide, the same type of protection, but there are differences in how to use them and how you take them off. So I think that is going to be one of the most important factors, is that whatever type of PPE that you're using, that the staff have learned how to do it safely. They know how to put it on and take it off safely. Paul, anything you would add?
Yeah, absolutely. I mean, I strongly agree with what you just said. I think it's knowing how to use it safely. I think, obviously one of the things that's really special about EMS is how often people transition from environment to environment, that they go from the patient's home or the street into the vehicle, into the hospital, back into the vehicle, into potentially their duty station. And I think, one thing that's really important to remember is that you have to transition your PPE with many of these transitions as well. And what I worry about with coveralls especially is that people wear it across too many different kinds of care environments, don't doff it when they need to be doffing it, and there's a real risk of contamination into what were clean environments. So I agree with Sharon. I think knowing not just how to use it, but when to use it, I think is really, really important.
Robert?
Yeah, I agree. The Donnan and Dolphin, we talk about preparation. That needs to be practiced quite a bit, especially if you're going to be using the reusable gowns or Tyvek suits and things like that. Deconning, using the EPA disinfectant is really important. I do want to caution on purchasing a mask. They're seeing a lot of counterfeit masks coming into the country. Please be careful with those. I know there was a lot of questions in there about fit testing and things of that nature. We really shouldn't be deviating from our normal practices, as you know, try to not to deviate from our normal practices as much as possible, right? And be prepared. Thank you.
Thank you all very much. Carol and Dave, thank you for sharing your experiences, the discussants for participating. Bruce, to you and your team for hosting the platform. Any final logistic, and for folks in the audience for providing significant comments and questions. Bruce, anything in terms of final logistics comments?
Great. Thank you, John. And thanks to Carol and also to Dave for fabulous presentations. The feedback has been really positive in the chat. Want to remind everyone, please, if you want the CME or continuing professional development credits, to go ahead and follow the links in the chat or in the announcement. And we look forward to your feedback. Stay safe and thank you.
And we look forward to your participation next week on EMS sessions and later in the week on critical care and emergency department, emergency medicine. Thank you all for participating. We greatly appreciate your interest. See you next week.